right. Hello, everyone. My name is Dr. Maridee Shogren, and I am delighted to come to you today from the state of North Dakota and be able to share some of our work with you regarding our Don't Quit the Quit program. In particular, today, we're going to focus a little bit more heavily on the work that we have done with the collaboration with our North Dakota WIC program, as well as several WIC agencies in the state. Today, I'm going to touch on a couple of key points, and that would be recognizing the importance of substance use screening within WIC agencies, and talk a little bit about the SBIRT technique, which can help people feel comfortable with asking those screening questions. And then we will spend some time talking about ways that we can reduce the stigma experienced by people who are pregnant and postpartum and have substance use disorders. So to begin, a little bit about our grant program. So what is Don't Quit the Quit? And Don't Quit the Quit is a grant-funded program that has been created to empower people who are pregnant or postpartum and in recovery from opioid use disorder. Our goal is really to help moms maintain their recovery. So in other words, we don't want them to quit the hard work that they have already been doing to enter into recovery and now can stay in recovery. We're housed at the University of North Dakota, and our two primary collaborators have been the Heartview Foundation, which is a program several hours from where we live that they work with people who have substance use disorders, and then our North Dakota WIC agencies. We are funded through the Foundation for Opioid Response Efforts, and we were in the first round of funded grants that came through in 2020. So as you all know, that was about the time that COVID was hitting. And so everything that we initially envisioned with this grant program actually changed over the course of the past 2 years. And we created a much more virtual friendly type of a grant program. If you're not familiar with North Dakota, we thought giving you a little bit of a graphic to see where we are might be helpful. Our service area started out in just 8 counties of North Dakota, but we quickly expanded to 12 counties, and we are in the northeast, north central part of North Dakota. Okay. All right. So our Don't Quit the Quit program was developed with 3 aims in mind. And the first was access. So we set out to increase the number of healthcare providers who were able to prescribe medications for people with opioid use disorder. Now, we did encounter a couple of providers who were already waivered to provide the service. However, they were not actively working with pregnant and postpartum people. And so one of the things that we really tried to enhance was their ability to feel comfortable prescribing buprenorphine for pregnant and postpartum people with opioid use disorder. We ultimately ended up working with 7 different clinic systems in our 12-county region, and were able to provide waivers to those providers. The largest piece of our Don't Quit the Quit program really focused on education. And we really developed this to be community education, meaning that it's education that families, people with substance use disorders, local members of the community, as well as healthcare providers could all feel comfortable attending and learning from the type of education that we provided. We specifically worked with our WIC agencies to do some foundational training, and I'm going to give you a little bit of an overview of what that content looked like today. And then we offered free monthly educational webinars that anybody could listen to via Zoom. They could attend live. To date, we have 18 recorded webinars that are on our website and accessible to anybody who would like to view them. For moms who participated in our program, they became eligible to receive diapers if they participated in the educational training. And then the primary goal of our education was really focused on decreasing the stigma that people with substance use disorders experience, especially in rural North Dakota. And then the third goal of Don't Quit the Quit was to increase our overall postpartum community support. And we were able to train 9 community members to become postpartum doulas and become the postpartum experts in their home communities. Okay, so a little bit more about the education that we included in our collaboration with WIC. So we first started out by meeting with our WIC directors to determine what type of content they felt would be most helpful to their staff in their WIC agencies. And we started out with a 90-minute foundational webinar where we talked about perinatal substance use. We went through all of the different substances and what their potential impact could be on mom as well as the fetus. And then we covered that same information as it applied to those who are breastfeeding. We highlighted opioid use disorder. We introduced them to the SBIRT technique, and then we included content on stigma. And that was just the first place that we got started. We continued our relationship with them really over the past 2 years. All of their staff were invited to participate in our monthly webinars. We ended up adding a special topic webinar that focused on nutrition during recovery from opioid use disorder. Then we expanded and included them in a 6-hour Train the Trainer event that we ran in collaboration with SAMHSA. We completed that just this past April. And then in June, we met with them to talk about the dilemmas. So as they were screening moms in their agencies, what questions did they have? What concerns did they run into? Where were they struggling with answering those kinds of questions? And we helped them through that particular content. And our last deliverable, if you will, is now that we are working with them to develop an infographic that they can use for education for their families. Okay, so why is the work that we're doing so very important? And really, we are on this mission to increase awareness and understanding of perinatal substance use. Many people ask us how often we encounter pregnant people who are using substances during this perinatal period, so during their pregnancy and the entire first year postpartum. And this is probably the most substantial graphic that we could come up with. And it's data that was put out by the National Survey on Drug Use and Health. Now, this came out in 2020. Their 2021 data, secondary to COVID, did not differentiate the different substances in the same way as used by persons who are pregnant. So we felt that this gives you the best picture, and it has stayed very steady at this point. So it also breaks it down to illicit drugs and includes tobacco and alcohol. And one of the things that we learned, especially when we were educating about opioid use disorder, is that people often forgot about the impact of alcohol use in the perinatal period as well as tobacco. So we wanted to be sure that we highlighted this potential for polysubstance use that is actually out there for everyone. We know that women in particular are at their highest risk for developing substance use disorders during their reproductive years. And that would typically be between ages 15 and 40-ish or so in there. And that if they have disclosed the use of one substance, it is actually strongly correlated with that polysubstance use. And we also know that we have a very high unintended or mistimed pregnancy rate for persons who are pregnant with substance use disorders. And while in the general public, we see a mistimed pregnancy rate of about 50%, this goes up to about 80% in those with substance use disorders. So it's really a population where we need to continue to be active with the education that we provide. This data came out just in January of this year, and it looks at the number of pregnancy-associated deaths by cause and year. And here in this graph, we're talking about pregnancy-associated deaths, meaning those that occurred during the pregnancy itself or in that first year postpartum. And you can see if you look at the drug-related pregnancy-associated deaths, that's 11.4% of all deaths in this category. And so that really highlights the need that this is not a problem that is going away. It is something that remains very, very current. And it really tells us why we need to continue to provide education as well as screening. All right. When we started our training with WIC, we felt it was really important to, again, go back to this foundational knowledge. And so we wanted to provide some information in particular about addiction and some of the differences that we'll see in the female population as opposed to our male counterparts. And what we know is that females are now the fastest growing population of people with substance use disorders. Sex and gender greatly impact some of the differences that they experience in addiction. And we're learning more and more and more all the time about the biological factors. For example, even things like how we respond to drugs and why menstrual cycles can even play a role in how a female will respond to their first use of things like stimulants, nicotine, or alcohol, for example. Gender-defined roles, we're seeing that change all the time. Some people don't identify with one gender. Literature tells us that transgender individuals may actually have an even higher risk of substance use disorders and abuse of substances. And we know that the gender role and their identity really influences how people perceive themselves and how they're able to interact with others, and sometimes contribute to the reason that they start using substances. Females in particular experience a phenomenon called telescoping. And this means that they will experience a faster onset from initiation of use to the onset of dependence of a substance. and to their first admission of treatment. So very quickly, they progress into a substance use disorder, making them more chronically ill at the time that they present for treatment. We see this especially with opioids, cannabis, and alcohol. Because they come into treatment with this more complex clinical profile, we really have to make sure that we're adjusting the types of treatment that we're offering them to include not only medical treatment, but really looking at that behavioral health aspect and their social concerns when we're looking at treatment. Females do have differences in their stress response and their stress reactivity. And consistently through the literature, you'll see that women in particular will often tend to maintain their social network. It tends to be something that they're pretty public about when they start using substances, but as they sink into that addiction, they tend to isolate themselves. So when we're talking about this perinatal period in particular, being really worried about those moms, for example, who may be becoming stay-at-home parents once their child is born, or have that extended maternity leave or time at home where they would just naturally be alone. So we need to be careful with that. And then we have learned that females are more susceptible to drug cravings, which increases their risk of severe withdrawal and overdose. Certainly, emotional, negative, affective states will make a difference in how they respond to substances, and that females do have an increased vulnerability to initiate that drug use, often as a coping strategy. We see this with things, for example, if they're looking at weight control, or they're just so tired in the juggle of being a mother and maybe holding down a job. And so often stimulants or nicotine might be started in these particular instances. And then they get this emotional response to that substance. It helps them feel more calm, helps them feel that they have more energy, for example, and that becomes part of that cycle. We also know that females do have a different sensitivity to pain than males and are more likely to experience chronic pain. They're often typically prescribed opioids at higher doses and for longer terms of use than men, and they may be more likely to self-treat or seek those prescriptions from multiple sources to take care of the chronic pain that they're experiencing. Females do absorb, metabolize, and eliminate drugs and alcohol differently than our male counterparts. And we find that females have a higher blood alcohol concentration after consuming the same amount of alcohol as males. And this is because we do hold a smaller percent of body water. We have fewer stomach enzymes, the alcohol dehydrogenase, to digest and metabolize the alcohol after it enters our system. And sadly, we do have a little bit more fatty tissue, which also can slow down this process of metabolism. And as a result, we have higher concentrations of alcohol that stay in our system, and this can greatly impact the amount of alcohol that's able to occur through the transfer to the fetus. We also see a similar phenomenon with oxycodone concentrations in the same amount of use between a female and a male. The percent can be up to 25% higher in females than in males. We also see higher rates of co-occurring disorders among females with substance use disorders. And when substance use disorders and mental health conditions occur together, symptoms tend to be more severe and more persistent. So for example, if we pair an eating disorder with a substance use disorder, chronic drug use can enhance that vulnerability for mood and anxiety disorders. It's a little bit like that chicken and the egg. So say, for example, if we have depression and we look at somebody who's self-medicating through the use of substances to try to address that depression, it can continue to cycle. And in the same instance, we can have somebody who has developed a substance use disorders and then trigger some mental health concerns. So we really do need to address the care of both of those concerns together. And then finally, we like to remind people that 1 in 3 females have experienced intimate partner violence. Up to 99% of them have experienced lasting trauma from this type of an abuse, and up to 9% of people who are pregnant will experience perinatal intimate partner violence. This is more likely to occur in African American and American Indian or Alaska Native people. We know that females who report perinatal intimate partner violence are also at an increased risk to use substances, and typically, we will see a report of substance use coercion tactics being used as part of intimate partner violence. So all really important things to be aware of and understand that they can contribute to the chronic disease of substance use disorder. We always do like to include a little bit of additional information about opioids, simply because we are a grant that has been funded to address the opioid use disorder epidemic. We know that females have been disproportionately affected by the opioid epidemic. So as a foundation, again, opioids are used to reduce the intensity of pain, but they can also cause the sense of euphoria. And that is something that might help trigger a person to want to continue to use an opioid. Opioids are linked to respiratory depression, increased risk of infection, particularly if they're injecting the opioids, dependence, overdose, and even death. And when we have a pattern of opioid use that's characterized by tolerance, craving, and the inability to control use, and that the fact that they will continue use despite adverse consequences, we have the development of an opioid use disorder. Opioid use disorder is considered a chronic disease. And when we move into the section where we talk a little bit about stigma, it's really important for us to remember to look at substance use disorders through the lens of a chronic disease. Opioid use has been on the rise in our country since the late 1990s. We have seen 3 separate waves of opioid overdose deaths. In the 1990s, they were contributed to an increased use of prescriptive opioids. By 2010, we saw a rapid increase in heroin overdoses, and by 2013, we saw the rise of fentanyl or synthetic opioid overdoses. It wasn't until 2017 that the opioid crisis was actually declared to be a public health emergency. And still to this day, we are seeing at least 128 people die every day from an opioid overdose. We have technically entered into a 4th wave of these overdoses, and that came along with the rise of stimulants like methamphetamine and cocaine being used alongside opioids. Opioid overdose deaths have increased 471% in women over the past 15 years. So when we look at the impact of perinatal opioid use disorder, or using those opioids during pregnancy or in that first year postpartum, we know that any substance has the potential to cross to the fetus during pregnancy. Opioids transfer very, very easily from mom to the fetus. So they don't get filtered out in the placenta, and they tend to move into that fetus and hang out for a while because we have an immature person who doesn't have the capability of fully being able to metabolize opioids yet. Opioids transfer because of their properties. They have a low molecular weight, they're water soluble, they like fats, and they have a longer half-life, so they hang out. Because of these properties, they tend to reduce the blood flow and the oxygenation to the fetus because they vasoconstrict or shrink down that ability of that umbilical cord to transfer that blood through. Because of that, we see a direct impact on the placenta. This leads to overall growth defects where we might see smaller size babies, lower birth weight, for example. And some of the news literature has even found a connection to hearing loss in the newborn. On the obstetric side of things, people who are pregnant and have an opioid use disorder have a 6 times higher risk for complications during that pregnancy. We see increased risks of 3rd trimester bleeding, placental abruption, where the placenta tears away from that uterine wall prior to delivery of the baby. It might be connected to preterm labor or birth. We see that there is fetal distress that's known at the time of delivery, and we do see a slightly higher risk of stillbirth. The opioids do alter brain growth and development, and we see an ongoing link to a cognitive impairment. So verbal, arithmetic, and reading abilities tend to be impacted in newborns and into that early childhood. The tricky part when we're educating families about the impact of opioid use disorder is that we don't see very clear-cut external physical anomalies. And so sometimes families will say, well, the baby looks normal. I don't see anything that looks wrong. But it's harder to process that cognitive impact that can happen, or have help them understand why a low birth weight baby could come with its own set of complications. We also see a 4 times higher maternal mortality risk for pregnant people with opioid use disorder. We do see this particularly impacted in our rural communities. One, they often don't have the ability to have obstetric care, or they have to travel really far to get this care. They might not have the option for continuity of care after delivery, and they just overall can have a limited access to healthcare because of the rurality of where they live. Now, the primary complication that we do see from maternal opioid use disorder is connected to the withdrawal symptoms that a newborn can experience after birth. Two terms that we'll talk about. One is neonatal abstinence syndrome, which is a very broad, non-specific term, and it's assigned to a withdrawal presentation in a newborn. This is not limited to opioid use. This could come from antidepressant use, it could come from nicotine, it could come from alcohol use or stimulant use, for example. We do know that if a substance use disorder is present in the mother, that we do see the symptoms of withdrawal to be expected, but they are treatable. So 45 to 94% of infants who have been exposed to substances during their pregnancy will experience some type of a withdrawal syndrome. The most common types of symptoms that we do see include irritability, excessive crying, poor sleep, difficulty with suckling or being able to coordinate that suck so that we don't have a direct impact on nutrition. Their breathing can change. They have an increased heart rate. They have a risk for seizures. They're just honestly a more unconsolable infant as they present. Now, if we look specifically at the withdrawal symptoms that come from opioid exposure, the newer shift in the terminology is that of a neonatal opioid withdrawal syndrome. This term is specific to the opioids, and it can occur from illicit opioid use, or it can occur from the medications that we use to treat opioid use disorder. Now, if we're talking about buprenorphine or methadone for the treatment of opioid use disorder, please know that these types of withdrawal symptoms tend to be more mild, and they're also more readily managed. So it is something that moms do need to be aware of, but we need to make sure that they understand that it's a more treatable type of a condition. We also see a sustained increase of neonatal opioid withdrawal syndrome in our rural residents. And again, simply because of lack of local treatment options and resources, the stigma is prohibiting many people from coming forward to disclose their opioid use disorder. And then we always need to consider that impact of finances. So if we have an infant born with withdrawal symptoms in a rural setting, we often have to transfer them to another hospital following delivery so that they can get that NICU care. This separates families. It makes it more difficult for bonding, and it even makes it more difficult for those families to participate in that newborn care. So it's an ongoing impact of, again, what that rurality can do. Okay. So then how do we go about screening for substance use disorders during the perinatal period? There is a technique called SBIRT, which we're going to go through by all of the different pieces. And we've found with its use over the past several years that it really does improve maternal and fetal outcomes. But we have also learned that many people still aren't screening for substance use in the perinatal period. So if we break down SBIRT, it's really telling us that it stands for screening, brief intervention, and a referral to services for treatment. Screening means that this is a universal, quick assessment, something that we can do in many, many different settings. And we learned from our WIC colleagues that there were already questions that were integrated into their intake appointments and standardized questions that they tended to use. We also can screen in primary care, in obstetric offices, social service offices, and even in public health departments. In this technique, when we talk about a brief intervention, we're really talking about something that maybe is 5 or 10 minutes. We're not talking about a long type of motivational interviewing intervention. We're really talking about raising awareness of the concerns of substance use in a perinatal period, and then using very short conversations to educate families about the potential impact. Maybe talk about harm reduction, ways they can decrease their use if they're not at the place where they can enter into recovery, and then prevention from the impact of substance use. And then finally, referral to treatment as it applies to WIC settings is really looking at that ability to have an options list for people to know where they can seek out local services for that treatment or that specialty care. So the technique is pretty straightforward, but many people are still not comfortable asking about substance use during the perinatal period. The top 6 reasons that we find for that include it's a difficult topic, there's stigma associated with substance use, there's a lack of time for people to ask those questions, people often feel inexperienced or they don't have confidence when they're asking the screening questions. If they don't have any follow-up treatment or referral options available in their area, they think, why would I even screen? They may be worried about hurting relationships if they've already established that rapport with an obstetric client, or they may just be convinced that there isn't anything that they ask that would even make a difference. When we really looked into the reasons behind why our WIC colleagues were not comfortable screening, the top two answers that we found were that it was a difficult topic. They really hadn't received any training about substance use disorders. There was some implicit bias, people concerned about the stigma that is associated to those who are pregnant and postpartum with substance use disorder, and they really just didn't have the confidence to engage in that conversation. There is much benefit to having conversations around substance use disorders. One, it helps us to maintain and encourage abstinence from substances during that perinatal period. It also helps mothers to stay in recovery. So providing that education about referral resources or the medications that they might be taking will also just help them feel comfortable with entering into treatment. It does help us to monitor any times of return to use, especially during high-risk times. So if you look at a pregnancy, that can be very stressful for families. If you look at the postpartum period, when they're really trying to juggle and become a new family unit, we really do see high stress levels that occur at that time. In particular, we know that the most often, if somebody is going to return to use in the postpartum period, it'll tend to happen between 6 and 12 months postpartum. And having the conversation around substance use disorders also opens up an opportunity for us to talk about harm reduction. When we look specifically at SBIRT and WIC, WIC has very clear guidelines that are put out by the USDA that talks about the use of SBIRT in WIC agencies. And WIC's role in preventing substance use is really to provide clients with education, increase their access to information about the dangers of substance use during pregnancy and while breastfeeding, and to facilitate those referrals for further assessments if it's appropriate. WIC staff are not expected to diagnose substance use problems or provide in-depth counseling. So we really have to look at this targeted approach in a very brief manner. As we worked with our North Dakota WIC colleagues, they did again explain to us that their data system was already in place and it already addressed that substance use screening, but their directors felt that this introduction to SBIRT really could help increase the staff's comfort with initiating those screening questions, as well as how to provide answers to the questions that moms may have and just talk about substance use in a very general manner. So key points to remember with screening: important to be open and non-judgmental. We want those screening questions to kind of flow through the conversation. We do promise you that the more often you ask those questions, the easier it becomes to ask those questions. So when you feel comfortable, your clients are more likely to respond honestly to your questions. Universal screening is ideal. We cannot and we should not pick and choose who we screen based on their appearance or based on bias. Now, if your WIC agencies don't already ask substance use screenings, there are validated screening tools for the perinatal population that might be an option for you to put into your existing system. They typically would include the audit or the audit Cs and the 4Ps. Now, the 5P screening tool does come with a cost, but the 4Ps is something that is available for public use. When we look at the brief intervention, again, very short conversation focused on education, harm reduction, and prevention. And we have introduced two different ways to have that conversation for this brief intervention with WIC clients. The first one, go with the flow, really lends itself to a more validated type of a tool. So you have the client fill out the tool. That tool is often given a number. And then based on that response, we start out with some feedback. And we ask if it's okay to talk with the client about the answers that they provided in that tool. Then we listen to their answers, we clarify their responses, and then we provide them options about educational materials and local providers who might be able to assist them with any concerns that they have. In the WIC agencies, so far what we've learned that the favorite type of brief intervention tool is the one that we call It's Okay to Cuss. With that method, you use your standardized questions that are already in your WIC database. And then once you're going through those questions, you simply say, I'm concerned about the number of drinks that you are having in a day, or I'm uncomfortable with the idea of keeping your substance use to yourself. I do believe that your safety or the safety of your baby could be at risk if you continue to misuse your opioid prescription. So coming up with just a short acronym, CUS, to be able to facilitate that conversation to talk about the substance use that they have identified. And then finally, for the referral to treatment, we know that WIC, you have choices as to where you're able to refer your clients. So maybe you refer them back to their obstetric provider with simply saying, based on the information that you've given us today, we really encourage you to share this with your obstetric provider. They may be referred to a primary care provider or a behavioral health provider. If you have a treatment program in your area, that might be the next step. So we encourage you to know where your local resources are and how you can connect those clients. If your agency allows for a warm handoff to facilitate that phone call and the process of getting an appointment, that is ideal, but we know that's not always an option. It is important to remember that we must meet our clients where they are. And this is very, very difficult because many of us will look at the information that they've shared and we will recognize the importance of seeking treatment or entering into recovery. If a client is not ready to go there, we do need to provide that non-biased awareness, the potential impact of substance use, what that impact is not only on the mother, but on the fetus or the infant and the families. And then we can just simply explain that providers might be able to help them either monitor their use, start counseling, or start medications, or maybe all three. So as that final reminder, it is not the role of people in WIC to diagnose a substance use disorder, to fix the people that come to see them, or treat their addiction. It's simply to create that awareness and help get them to the resources that they are open to accessing. We also learned from our WIC colleagues that they were a little fuzzy on what that treatment for opioid use disorder may actually look like. So here we're going to talk about medication-assisted treatment, and know that this really is the gold standard of care for people with opioid use disorders, and this should not be altered simply because they are pregnant or they are postpartum or they're breastfeeding. So medication-assisted treatment means that we are using medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of the substance use disorder. Counseling and peer support can really encourage and motivate people to enter into and maintain their recovery. We're learning more and more and more about that value of peer support and peer recovery support specialists. So also including them in your local referral list. The medications that we're talking about here include methadone and buprenorphine products. You may have heard something, for example, called Suboxone or Subutex. These are buprenorphine products. They both can be used very safely and effectively during the entire perinatal period. Again, that means during pregnancy and in that first year postpartum. There's minimal risk to mom, minimal risk to the fetus. And in fact, if a mom is started on treatment for opioid use disorder during her pregnancy, there is some findings that tell us that this may actually lessen the need for pharmacotherapy for a newborn who has some mild withdrawal symptoms. There are medications that are also appropriate for use during breastfeeding. Again, there is minimal transfer in the breast milk of these two products. The goals of medication-assisted treatment are really to manage and prevent those withdrawal symptoms in mom so that we're able to reduce the cravings that she may be experiencing. It helps us prevent overdose and it prevents that return to use risk. It also, because of the properties of these medications, kind of puts a cap or a ceiling effect on this euphoria. So these two types of medications aren't going to trigger that euphoric response. It's really more to help keep those cravings under control and it also helps increase their adherence to prenatal care, which then trickles down to decreasing those obstetric complications that we can see. The overall maternal fetal impact is improved survival. It increases their retention in treatment as well as prenatal care. It decreases their illicit opioid use and the infections and things that come along with that. It also helps them to improve our birth outcomes, which ultimately leads to improved childhood outcomes and family outcomes. Okay, so the next topic we want to introduce you to is a little bit of the material that we shared with our WIC agencies regarding the stigma that people with substance use disorders particularly experience during that perinatal period. When we came up with which definition of stigma that we really wanted to share with our families, this is the one that I typically use. Stigma is an attribute that is deeply discrediting and reduces the bearer from a whole and a usual person to a tainted or discounted one. And that one really spoke to me as to a reflection of how we look at people who are pregnant or postpartum. Often mothers feel less than already. And when we add that substance use disorder and the stigma that goes along with it, it just makes them feel even more less than as the person in that capacity. We know that the stigma that's associated with substance use disorder is a 100% barrier to their ability to seek treatment, to be screened for substance use, and even to disclose that substance use. People who are pregnant and parenting are particularly impacted from stigma in very unique ways. So if we look at stigma, mothers, and substance use disorders, some of the key differences that we found. Number one, cultural kinds of differences. So females in our country are viewed as mothers, caregivers, and gatekeepers, meaning they're central to that family unit. Everything is kind of built and circles around the mother in that particular family. But mothers who have disclosed that they have a substance use disorder are often considered to be very selfish. We tell them that they have a moral failure. They have been told that they are trying to cause intentional harm to their families, and therefore they place an entire burden on our society. And because of these cultural beliefs, we believe that this really drives the self-stigma that pregnant and parenting people do experience. It internalizes their narrative, so they have a lot of blame, shame, and guilt, and it helps them to, or it causes them to really struggle between secrecy and disclosure. Do they share their substance use disorder? Do they enter into treatment, or do they keep it to themselves because they're so concerned about the impact of that disclosure? Mothers with substance use disorder will perceive this type of stigma throughout the entire perinatal period. So this stigma comes from healthcare providers. It comes from the public. It comes from their family. It comes from that internal stigma that's there. And interestingly, they even experience a difference in stigma within their addiction community. And here we're talking about if they're already participating in, say, a self-help group, for example, or a peer recovery support group, that they often sense this great support for their recovery. But if they disclose that they were pregnant, that they sense this little bit of shift, that people looked at them different now because they were a mother in that capacity as a person with a substance use disorder. I have a little box over here to the side on this slide, and I really would like you to think about this. So if we have a mother with a substance use disorder, and she's not pregnant yet, but she's thinking about becoming pregnant, and she shares that, the perception often is, well, you shouldn't have a baby. You have a substance use disorder. You're not ready. You can't have this baby. If she becomes pregnant and she has a substance use disorder, we tell her she's hurting her baby. And when she's postpartum, the message that comes through is often, you can't care for your baby because you have a chronic disease, like a substance use disorder. So multiple places and multiple periods during this perinatal time where she experiences very unique stigma. Pregnant people with substance use disorders are often even prosecuted for their substance use. And I included a link here to the Guttmacher Institute website. It's a really interesting site to look at because they break it down state by state to identify the guidelines that are in place in those states as to what the screening process looks like during the perinatal period, what the punishment is potential in those states, and if there are any programs that the state uses or advocates for pregnant and parenting people with substance use disorders. Okay, so I want to take this idea of culture and stigma a little bit deeper, and in particular, really look at those healthcare encounters that people who are pregnant or parenting will have during this perinatal period. So each healthcare encounter is going to occur in the context of at least 3 cultures, and that includes the culture of the healthcare provider's lived experience. It includes the experience of the person who is actually seeking that healthcare. And it will include the culture of the healthcare system itself. We call this institutional stigma. So every organization, every institution has a different culture surrounding it. But I would also argue that there is the importance of a 4th cultural context, and that is our community's culture. So where do we live? If our institution is in a rural area, does that look a little bit different than something that's in an urban area? Our states will have different cultures on how we approach the care of people with substance use disorders. So potentially up to 4 cultural impacts that will occur during this time. Now, every single one of these cultures has a wide variation of attitudes, beliefs, and behaviors, and every one of them includes some type of bias and stigma. Please consider this next statement as we go through the next few slides. A single interaction with a healthcare professional can be empowering or one that negatively impacts all subsequent interactions. Please just keep that in the back of your head. So let's talk about these potentially negative type of healthcare encounters that people who are in this perinatal period will typically encounter. And they're going to include things like your perinatal visits, for example, going through that prenatal care, potentially even being seen at a WIC agency, whether it's a primary care office, obstetric office. So looking at those types of perinatal healthcare encounters. Renberger and Associates conducted a study that looked at 23 qualitative studies and compiled that information together. And they came up with the top 5 types of healthcare encounters that really stuck with people in the perinatal period. And the mothers reported back to the kinds of experiences that they had when they went in for things like a prenatal care appointment. The first type of visit they categorized as a visit that was very judgmental, meaning that the mothers sensed the provider's disapproval of their substance use disorder. They felt like the healthcare professional was looking down on them, and this caused them to feel shame, frustration, irritation, and they felt very dismissed, like they didn't matter during those visits. The second type of visit they highlighted was one that they called a scrutinizing visit, meaning that they felt that the entire time they were in that appointment, they were being observed, they were being monitored, and they were being questioned, not only about their ability to mother, but were they actually high? Were they under the influence of a substance, especially if they were trying to hold their infant or breastfeed their infant? This caused moms to just avoid prenatal care in general, or actually lie during these visits about their substance use disorder because they didn't want to encounter those behaviors. The third type of visit the mothers described was one recognized as a disparaging visit. This is where they perceived or felt openly critical behaviors. They saw the providers using eye rolling. They were whispering. Often they stood outside the door of the exam room and mothers could hear what they were saying, even though the providers felt that they were being quiet. And they were called names during these types of visit or told to get their life together. This just led to those overall feelings of just very, very low self-worth. The fourth type of healthcare encounter that mothers experienced was one that they called a disempowering visit. This caused mothers to feel like they had little or no control over their own health or their infant's health. They felt that they had no voice in their healthcare decisions, not only for themselves, but for the healthcare of their babies, and that caused them to be very, very frustrated and feel very angry. And then the fifth type of visit was one that was called deficient care. So mothers often felt that they received a lower quality of care simply because they disclosed their substance use. They felt that they were not given adequate health information, nor were they given enough time during their visit. And this often resulted in discontinuation of their care, that they just stopped being seen. So then I would like you to just consider this. Typically, a pregnant person will have at the minimum the following perinatal encounters. They will have about 9 prenatal visits. That's if they get started fairly soon in the first trimester. They might have 2 days of a stay in a hospital for their labor, their delivery, and their initial postpartum recovery. And if we're lucky, they will come back to see a provider for at least 1 postpartum visit. So here we're looking at about 12 different types of encounters that they could have. And if each one of those healthcare encounters occurs in the context of 3 different cultures, that means that if a person discloses the substance use during their pregnancy, they could face potentially 36 negative, stigmatizing experiences from routine prenatal care alone. This doesn't take into consideration the other interactions that they have with families, with friends, with colleagues, or those that happen in the first year postpartum. Newborn appointments, pediatric appointments, gynecology visits, WIC visits, those things could also lend to more stigmatizing visits. That is incredibly heavy. The consequences of all of these types of stigmatizing experiences lead to poor self-image, shame and embarrassment, fear, mental health concerns, suboptimal prenatal care. As we learned many times, they didn't even engage in prenatal care because of the stigma. They might not enter into treatment, or they simply will withdraw early from treatment, and it even can lead to death. So the consequences of stigma is huge, and it's something that we need to continue to educate on when we're talking about working with families who are in this perinatal period. So how then is Don't Quit the Quit working with WIC to address the impact of substance use in rural North Dakota? So we know that WIC is vitally important to the ongoing care that mothers with substance use disorders experience. WIC must be part of our interprofessional healthcare team. You are key to provide community education support, and you offer that key point of referral to care. We also know that WIC can help us fill the gap for continuity of perinatal care, especially during the postpartum period and especially in rural areas. Only about 40% of people will ever return to their obstetric provider for even one postpartum visit. And this is even lower amongst those in a minority or underserved population. After delivery, moms aren't going to engage in routine healthcare and will only seek emergency services if needed. Many lose their healthcare insurance by 6 to 8 weeks postpartum, and then they have inconsistency with providers, particularly if they've had one provider deliver their obstetric care, maybe a different primary care provider, and maybe even a different treatment provider. But people do continue to attend their WIC appointments, especially if they have established that relationship prenatally. So WIC support for people with substance use disorders actually influences their ability to avoid return to use. It offers them nutritional support that is crucial to maintain their recovery, and it provides them with a place of acceptance and non-biased care that continues to help us break down that stigma. We do continue to work with not only North Dakota WIC, but WIC agencies across the nation. As I mentioned, we did include a nutrition-focused webinar that looks at nutrition needs during opioid use disorder and recovery, and that is available on our website. We've done some extra work in South Dakota where we included content and webinars on perinatal mental health screening as applicable in WIC settings. And we've even offered this 6-hour Train the Trainer event with WIC agencies throughout Region 7 and Region 8. And we just presented our Don't Quit the Quit work at the Texas WIC Association. We're currently working with the USDA, SAMHSA, and Don't Quit the Quit to come up with a way that we could expand this training nationally. You can also help us continue the work through Don't Quit the Quit, and we ask that you help us promote health and decrease stigma, and recognize that if we're going to provide adequate perinatal care for people who are pregnant, postpartum, and breastfeeding, we need to do that in a way that prevents stigmatization and discrimination and marginalization, and it actually promotes that healthy family and community and social support. Please remember that your language matters. We ask that you view addiction as a chronic disease and not a moral shortcoming. We encourage you to use non-biased language in your healthcare encounters. Please correct the misinformation that is out there and share only the evidence-based education that is available to us. We ask that you continue to engage in training for all of our healthcare professionals, and please consider the use of SBIRT. It is also important to recognize that as you engage in this work and you do the work to help care for people with substance use disorders, we can all experience distress. We can experience moral distress, and we often will experience compassion fatigue. So remember to become aware of our own biases. Become aware of local and state treatment options for people who are pregnant and parenting and have a substance use disorder. And we encourage everybody to talk with people who have lived experience with substance use disorders. This slide has content that came from Mothering and Opioids, Addressing Stigma and Acting Collaboratively. It was a document that was put out in 2019, and it gives us an insight into what mothers with substance use disorders want us to know. They want us to know that mothers want to succeed. We should not assume that they're not trying or that they're choosing these challenges. They ask us to show empathy and not pity. They ask us not to judge, but to care. And they encourage us to listen and be curious to learn about what works for each of them as they work to treat their substance use disorder. And finally, we ask that you visit us. Please come to our website. We have the URL listed for you here. It's just at Don't Quit the Quit. We have 18 recorded webinars that are available for you to listen to, share with moms who have substance use disorders. They're all free and available to you. We also have some professional resources. And in addition, you can follow us on Facebook. And if you have any questions, please don't hesitate to email me at maridee.shogren@und.edu so that I can help connect you to those resources. Thank you very much.